So in a second here, it should be live. And just so people know, last time there was problems with the Facebook. So we're just taking a second to make sure everything is working. It appears to be this. Oh, no, we have this may be an issue on its end. Just remove this from the stream and re-add it.
So it looks like I'm live on my end, and yeah, everything is looking pretty good.
It looks like two of the Facebooks are not working. It looks like your Facebook is working, but it looks like the one on so give us just a second while we fix this.
We'll be right back here in a moment.
Yep,
we'll be right back.
Just a second. Okay, I'm going to try to add it again. Well, hopefully everyone's doing well. Okay.
Oh, absolutely.
Let me see. Yeah, I don't know why it's having problems, but it is having issues. I'll try this again. Save changes. And it's reconnecting right now. We're going to remove this one. One more second, and then we should be good. Oh, we have people coming. That's great. We can probably take a question here. So tonight we're going to be talking about the biggest thing we want to talk about today is when do you see a doctor? And I think I got everything set up now, so we should be good now on Facebook. Okay, we're good on my end now. You're good on your end?
We're good. We're ready to rock and roll here, yeah.
Fantastic. So, you know, we were talking about topics to talk about, and I think one of the things that comes up a lot is, you know, when to see a doctor. And I think, you know, it's, I really am interested in what people have to say, because obviously you and I, we have our, you know, our board question of when does someone see a fertility doctor, and we have the rote memorizing, you know, answer that we're supposed to say. But in reality, I mean, it's not the same for everyone, right? And I think that's really, you know, what I want people to understand tonight is, you know, whether you are having fertility or not, you're just trying. You just want to know, hey, when should I see a doctor? I mean, if I'm not pregnant after a few months, do I see a doctor? And so it'd be kind of really interesting, you know, to see, you know, what people think about that. It looks like we'll have to wait on one of the people because it looks like their mic is not connected yet. So we'll send them. But you want to start off by just kind of, you know, I mean, tell them what the generic, you know, the first generic answer is, which I think all of them can find on Google.
That's right. That's right. Also, I'll take generic answer number one for 500 here. So I mean, basically, you know, the classical teaching when we talk about when is the appropriate time to see a fertility doctor is that if you're below the age of 35, you should try for a year, assuming you don't have anything that you know causes infertility and that you are having regular ovulatory cycles with like a positive ovulation prediction kit, and you're able to have sex around that time. So that's kind of the first answer. The second answer is if you're above the age of 35, that needs to be shortened down to about 6 months, just because of the little bit more urgency to make sure that you've at least evaluated everything, that there isn't something there that you're, you know, up against the clock. And actually there's another third part to that, which is that, you know, at the age of 40 and up, it is considered very fair to start the evaluation, even when you just start trying to get pregnant, just to know where you're at with everything. So these are kind of, I think, the generic kind of board questions, as you'd say it, Dr. Amols. And I think there's a lot of like truth in them. So I think there, you know, it's not, I would never sort of put those aside and say, no, here's another set of rules. But there's kind of the kind of official dogma of it. But, you know, we're kind of joking around, but I mean, tell me what you think are some of the issues with that. I mean, why is that a little problematic from your opinion?
Yeah, well, I think first, even before we get that, defining, you know, kind of what infertility is, right? So, because one of the things I get people who come in and say, well, we haven't really been trying yet. I'm like, oh, what do you mean? And oh, well, we've been together for, 10 years, but we haven't really tried. I'm like, oh, okay, so you've been using condoms. Well, no. Oh, then what are you using? Oh, well, we're using the pull-out method, coitus interruptus. And I tell them, I go, what? That's a fair method once in a while, but technically speaking, it has a failure rate, and there's a reason why Trojan is a billion-dollar company, because it doesn't work that well. And so I think the first thing is, what do we even call infertility? I mean, how much do you have to have intercourse, right? So some people say, well, I only have intercourse twice a week. That's enough, And so I think first the definition is what does it take to get pregnant? Do you really need to check ovulation? Do you really need to time it? Do you have to have intercourse every day? And so I think that's the first step, is get people to understand that you don't have to try to get pregnant. Now, it doesn't mean you can't just have intercourse once a month unless you're literally landing on the day, but you don't really have to try to get pregnant. And that's why there's many 16-year-olds out there who get pregnant. They don't want to. They're trying not to, and they get pregnant. And then there's some of us who, we don't get pregnant. We just assume that we're not trying. And so I think that's the first step, is when you're trying to define it, of those, a year or 6 months, is what is trying? And, I don't know what you think about that. I mean, do you agree that you don't have to physically, sorry, I'm pulling this over, physically have to, try?
Exactly. I mean, I just remember talking to so many couples where they come in and they're like, well, we've only really been trying for 6 months. And then you dig a little bit deeper, and what you find out is that, they pulled the goalie 2 years ago, right? They really have said that they've been having intercourse without using any contraception for 2 years, but trying for every individual and every couple does seem to look a little bit different. I think there's a lot of variation there, which is interesting. For some people, trying means that they've done, ovulation prediction kits, and they're using the app, and they're having sex every single day right around the time of ovulation. And if they didn't do that, then they're not really trying. But that's not the barometer. That's too high of a standard, if you will. And so, yeah, I think it's absolutely a critical question to ask, oneself, like, very honestly, like, okay, how long have we actually not been using contraception? Or said it in another way, how long have we been making sure it doesn't happen, right? Because that's really the window of how long you've kind of been trying. And I think it's very telling. Some couples will come in and they'll say, we haven't used contraception for 7 years, but we've only been trying for the last year. And those couples, I'm a lot more concerned about what's happening in the background, as opposed to somebody who said, maybe we just got, married a year ago, and from that point we've been having, kind of unprotected intercourse, or something of that variation. So I think there's a lot there, and it's important to make sure we unbundle it.
Yeah. It's interesting. The other situation I have where couples come in, I'm sure you've had this, is they're like, oh yeah, we got pregnant easy the first time, and now we're not getting pregnant. And I'm like, so I'm trying to figure out, I'm like, okay, so you got married here, and then you got pregnant 6 years later. I said, so you guys are using protection? Well, no, we weren't really trying. And then again, that's that same situation. Now there's a history of infertility there. And really, their doctor would have recognized that at that point. Their OB doctor, and again, they're not fertility experts, so I don't expect it. But they might have said to them, hey, next time you try, you might want to, in 6 months, if you don't get pregnant, come see us, because it really doesn't take 6 years. And it's just interesting. Some of us don't realize that. I didn't either. I mean, I remember when my wife and I, again, I don't like to admit this, but inappropriately, we were together when we were very young, and we, could have got pregnant all those years, and we didn't. And then there was years we tried not to get pregnant, and then there was years where we're like, okay, if it happens, it happens. And you almost, as a patient, you kind of have the mindset, have this feeling like, well, we're not trying, so if it doesn't happen, it makes sense that's not happening. So in your mind, you almost trick yourself to think, okay, well, it's not happening because we're really not wanting to happen. We're just saying, if it happens, we'll let go. And I think part of that kind of plays into that. So then, it's like a year or so, 2 years. I'm like, well, now we're ready. And then they start trying, it doesn't work. And then realistically, like you said, really the clock started back then. I liked your analogy, pull the goalie. And so I think that's one of the most important things for people to understand, is you don't have to try. And I think once you establish that, Then you get to the next part, which is what you said, is that there's nothing that's abnormal. And so, the things I think of when I think of abnormal is irregular periods. Anyone who doesn't have an irregular period, you don't even have to wait 6 months. If your period's coming once every 50 days, 60, 70 days, don't go past go, just go straight to the doctor, and at that point, because something's wrong. I'd say the same thing with guys. If you're having problems getting erections or, problems with ejaculation, your testosterone level's low, go to the doctor right away. See a fertility doctor, at least to get those things figured out. History, I think people with severe, pelvic pain with their periods, people who have pain with intercourse, just constantly, high chance they have endometriosis, right? I mean, 6 months at the most, go see, I don't care how young they are. And then the other area I think is, you see these couples where, like I said, they weren't trying, but they're just like, we've been together for a long time, but, we've never really tried. And like I said, same thing, like, I don't even know if you need a first try for 6 months. At that point, just go, we've been together a long time. We've never used protection. Just go see the fertility doctor. Save yourself the time. Now, the problem is that it's important for your doctor when you see them to put in there that you've been still trying because, for insurance purposes, but technically you have been trying as long as you haven't been using protection.
Yeah. That's such an important point in all of this. And I think, underlying all of this is something that I think is like really important to just like touch on for a second here, which is that all of us, I think, when we're trying to achieve something and there's a little bit of like subjective time in the background, we all have a little bit of denial, like even if you take it from any angle, like if you're trying to lose a little bit of weight, if you're trying to, get it back into shape and I don't know, you have some thing that you want to do, run a mile in X amount of time. And there's always a little bit of like, well, I didn't actually start trying until this point. And I think that's like just human nature to do that. And so sometimes we just have to be a little objective about it and take a step back. And I think that's a really important part of thinking about when to see a fertility doctor. Now, let me ask you something here, because I think it's, something that's happening more and more and more. And it's a really important, part of the group of people that we see. And that's the group that is really trying for their first time. Maybe they were contracepting and everything, and they're about 40 years old, 39, 40, 41. And they're just going to start trying for their first time. And I think there's maybe a little bit of confusion in this group about, when to, seek care, what to do. Like, doesn't mean you immediately have to go to treatment, but maybe it's an important age to be a little more proactive about things. And what's your approach on this?
Yeah, I think it's kind of interesting. I thought first you were going a different direction with this about like, how age can affect things and stuff like that. But, I think anyone wanting to first have a kid, I think the first thing to do is if you're like, okay, we're ready to start, they should always go see their OB anyways, right? So, we talked about this, you and I, many times, going to get prenatal labs, making sure that things are healthy, because one of the things is you want a healthy baby. That's what everyone wants. And so it's always good to see your OB/GYN. And the nice thing about at least starting there is it kind of starts the clock, right? Now that OB/GYN knows, they evaluate you. And although OB/GYNs are not infertility doctors, they do have some knowledge of, knowing when things maybe you shouldn't wait so long. So for example, if you're someone who's not getting a period, they're going to tell you, okay, we'll try this medicine such as letrozole for Femara. If it doesn't work, or Clomid doesn't work, then we'll send you off to a fertility doctor. And so I think the good thing is by starting there, I think the OB/GYNs are great to start with, even if at the first month, because you can start doing things like genetic carrier screening to make sure that, you guys don't have any genetic diseases that you can be passing together, recessive diseases. You can check your, hormones, make sure your thyroid's normal, to make sure you have a good thyroid level. So I think that's the best place to start. I think the question, and then we even saw it come in our feed here, is that, but when do you say something to your doctor, right? Because there are some doctors who who do feel like they're fertility doctors, they think, and they're like, oh, we're gonna keep trying this, trying. I've seen people on Clomid like 12 cycles. I'm like, oh my goodness. And I think, that's another hard part, is because the fertility doctor is kind of like the gatekeeper in some ways, right? Most people are looking to them to decide when to see a fertility doctor. And so that's part of why I wanted to do the show today in this topic, and I know you did, was to explain to people that no, you can go before then. You don't have to wait for your OB doctor. And so branching off on that a little bit, based on a question where someone said, hey, how do you know when your doctor's giving you letrozole when to go? There's this general rule that, think of the number 3, and that is, usually people get pregnant after 3 tries of something. Now, it doesn't mean everyone gets pregnant after 3 tries, but statistically speaking, about 50% of people are pregnant after just 3 months. It really is that fast in the young population that Dr. Salem was just talking about. Now, if you're not ovulating and they put you on Clomid, it's not unreasonable to do 6 months of it if they know it's working. But at that point, that would be treatment. You don't want to continue actually doing treatment with the OBGYN for more than 6 months. As I say, any type of treatment they're giving you to help you get pregnant, unless it's working, meaning you're getting pregnant and then maybe it failed, but you tried again, I'd say 6 months you see a doctor, because that's basically jumping ahead of even trying a year. Trying a year is on your own. But once you have an OB involved and they're helping you, 6 months at the most, I'd say you go and see a fertility doctor at that point.
Yeah.
What do you think about that?
Yeah, no, I think I think the key things there too, like for me, that I hear from that, is the importance of plugging into an OBGYN as a jumping off point. A lot of times they are, very, very happy to get your preconception labs going and make sure that you're in good health in order to have a pregnancy, et cetera. I think a preconception visit is a great idea for everybody. I wish more people did that. And quite honestly, this is kind of like, I think, something that doesn't exist. I wish men and women had preconception visits, and for right now, there is no such thing as a men's preconception visit. I kind of think we do some of them. I definitely see patients where they come in, they're like, we haven't really started trying yet, but we're thinking about it. And we have a discussion with both of them. All right, what's your lifestyle look like? What's this on? And then sometimes things pop up, medication you shouldn't be on, or a supplement that isn't so helpful, or something like that. So I think there are some things that can also hinder fertility. They can hurt your fertility.
Yeah.
And those are things that, as both OBGYNs and especially in our world as fertility doctors, we can kind of pick up on those things, through a discussion, as we go through things with people. So I think the importance of like this preconception visit or early visit can be very, very helpful for couples early in the journey.
Yeah, you kind of picked on something about hurting things. I'll see patients with OBs, naturopathic doctors, and they're doing certain treatments that can actually hurt them. For example, I see a lot of progesterone supplementation occurring out there. And again, there's nothing wrong with that. No one got harmed by it. But, if you're doing it for a year and a half, 2 years, that's where the harm is coming. And so I do think, like, I go back to that point. If someone's helping you do it, that's not a fertility doctor, if they haven't got you, at least working in 6 months pregnant, see a fertility doctor. There was something I was just thinking about. I was gonna talk about was planning. So not everyone wants 8 kids, okay, but some people want a lot of kids, and I think that also plays a little part of when to see a fertility doctor, right? If you're wanting 1 kid and you really don't have the money to go see a doctor, I think it's really reasonable. You're like, okay, we're in our early 20s. We'll just keep trying for a couple of years, and if it doesn't work, then we'll go see our OB, and if that doesn't work after a year, we'll go see a fertility doctor. But if you want a lot of kids, let's say you're 32, you have to start thinking about the longevity of you, as you once said before, your reproductive lifespan. And I love that word still. And if you're 32 and you want 6 kids, that's going to be very difficult. And so that's where you might want to see a fertility doctor, just for planning purposes. Maybe you want to like freeze some eggs for the future, or things like that. So seeing a fertility doctor isn't just always having infertility either. It could be that you want to prepare for when you want to have a kid.
Mhm.
My favorite comment I hear all the time was, "Yeah, my doctor said I had PCOS, and that someday if I want to get pregnant, I should go see a doctor." And I'm like, "Oh, okay, that was some good advice." So like now I want to have a kid, and even seeing someone earlier, they might be able to help you from not seeing a fertility doctor. So I see patients all the time, and they're not ready to have kids. I say, listen, get on this medication, do this, and you might not need my help at all in the future. We get
Yeah.
you ovulating on your own. And so I do think, as you said, that kind of preconceptual counseling with a fertility doctor is not a bad idea. I've had a few of those. I've had people come in and they're like, hey, we're about ready to have kids. We don't want to waste any time. We just want to get a checkup. And so they come in, they get their tubes tests and stuff like that. And I tell them sometimes they don't need to, but they're
Mhm.
like, listen, I'd rather check. And I think that's a really reasonable thing to do.
Yeah. I think I saw a question bubble up here
Oh,
on our feed.
on our comments.
Yep.
What would the recommended path for a woman who has follicles for being early 40s but does not have a regular menses discover there is a uterine fibroid? It's a great question. You want to start that one off?
Sure. Yeah. Like I'll maybe we can pick it apart a little bit so that we can
Yeah.
talk about each individual thing, because I'm hearing early 40s. I'm hearing a woman who has follicles but doesn't have irregular menses, and then there's a fibroid. So maybe we'll start with having follicles in the early 40s. So, most women in their early 40s are going to have follicles. I mean, uh, having follicles indicates that there are eggs there, and eggs that could be grown to ovulate, to be grown to do IVF with. So it's very, very, very normal for a woman in her early 40s to have follicles. The issue is not having the follicles. The bigger issue is the quality of the eggs therein. So, just as a broad example, when a woman's about 30 years old, the eggs that will lead to an embryo are mostly genetically normal, or mostly will lead to a genetically normal embryo. In other words, will not lead to a miscarriage, will lead to a healthy baby. So that's about 65 to 75% of the eggs are going to lead to a genetically viable embryo. By the early 40s, that number might drop down to about 35%, depending on which year in your 40s. Let's say it's 41. They'll drop down to about 35%. So you can see there's a really big shift in how many eggs are viable. And the other part is that there are way fewer eggs in a single cycle. So again, this is why understanding your ovarian reserve when you're in your early 40s can be really, really helpful in helping you make sound decision making about, how long does one try? How long does one try before trying IUI? Maybe if you have a lot of eggs, that makes you a little bit of a better IVF candidate, and you want to consider that path, earlier, let's say. Now, the second part of it is not having regular menses. So not having regular menses means a few things, but definitely one of the things that it means is that you're not ovulating regularly. And so it's harder to time intercourse, and it's harder to have the lining of the uterus match up with what the ovary is doing. It's harder to get pregnant, basically. But irregular periods can be due to a lot of things. And this is a very classic thing that we work up as fertility doctors. We try to understand, why are the periods irregular? It's true that like PCOS is one of those things, but there are many other things that cause irregular cycles. And it's really critical that you get the right diagnosis so that you can kind of treat whatever the issue is. So maybe I'll stop there, because I kind of took a couple of those, and I'd love to hear what you think about those. And then we should definitely talk about the fibroid, because the fibroid is a whole other thing that we can talk about.
So I'm going to talk about from the point of view of what we did this podcast. I mean, this show about, which is, when to see a doctor. So if someone was in their 40s, I would tell you, you definitely want to see a fertility doctor within 6 months. But when you add these other things, such as not having a regular menses, having a fiber in your uterus, I would say within even 3 months, I would say a fertility doctor, or right away. So in that situation, you don't want to wait And as Dr. Salem said, there are many causes of not having a period. It doesn't just have to be PCOS. You can have severe insulin resistance that can cause you to not get a menses. And in that situation, it actually can become somewhat dangerous, because if you have severe insulin resistance and you're not getting a menses, you're actually higher risk for endometrial cancer. And so there's even a medical benefit to it as well. When it comes to the fibroid, I know that's one of the parts we're talking on. I think the question I have for you, Dr. Salem, is, do you think, like, you and I know that not every fibroid is going to be a problem, but if someone's trying to get pregnant and has a fibroid, do you think they should just see a fertility doctor right away? Do you think if their OB says no, they don't have to? Because clearly you and I know that there are some that can affect it, but is it something where should they see someone based off of that, off of fibroid? I would say, for me, I'll be honest, I don't trust a lot of OB doctors. So that's when it comes to like making that decision. Because I've had people say, oh no, it's completely out of the way. And I look at it and go, no, it's not, it's here. But there are other things that fibroids can cause. So for example, fibroids can cause other issues like getting to the ovary. So if you're trying to do a retrieval, sometimes they can get to a point. So sometimes it's not just about the cavity, it's also about being able to get to the ovaries. I was just wondering what you thought about that with the fibroid, but everything you said, I agree with regards to the comments.
Yeah, no, it's definitely like, so I think this is a really interesting thing because, and I wish I would love to have, different folks on our show. And I'm sure we're going to do that soon, where we have like a minimally invasive gynecologic surgeon and, an OBGYN who delivers babies all the time, kind of share our different opinions. But I will say that one of the benefits of being a fertility doctor and going to a fertility clinic is that we look at everything through the lens of fertility. And we look at it through the lens, not just as fertility doctors, but also as OBGYNs, because we delivered babies, but also as minimally invasive surgeons. We've done a lot of these surgeries, in the past. And so when we think about fibroids, I think there are two sides to the same coin. On the one side, we want to minimize harm if we don't need to take the fibroid out. Fibroids are very common and they get more common as you get older. So a very high proportion of women, depending on your background, will have fibroids in their early 40s. It's super common. The question is, where is the fibroid and how big is the fibroid? And that can cause either problems with getting pregnant or staying pregnant or having complications during your pregnancy. So these are the kinds of things that I think you and I are really kind of looking at, and really kind of looking at it with a fine-tooth comb, really kind of going through how big is this fibroid? Could it possibly affect, the placenta in the future, et cetera? Or is it better to leave it so we don't compromise the wall of the uterus so that it doesn't maybe predispose you to a C-section down the road or something like that? So, I think the question around the fibroid is an interesting one. And I would say anybody who's having problems getting pregnant and an OBGYN said, hey, there's a fibroid here, this is problematic, I think it's a good idea to have a second opinion from a fertility doctor if you're going to go through some big surgery. And a lot of times, I would say probably the majority of the times we're going to agree. We're going to say, yeah, this fibroid's in the way, it needs to come out. But I do wonder about every once in a while when we have a case where it's kind of in the gray zone and we're like, well, maybe this isn't the primary reason for your infertility. If you're 42 and you happen to have a fibroid there, maybe the fibroid's not the reason for the infertility at all. It's all the other stuff.
Yeah, no, absolutely. There was a question asked here I thought was a good one. It said, if we've tried for 6 to 7 years with no success, would it be safe to assume we just won't conceive naturally? And, I don't think you can say it's safe to say you won't, but I think it's statistically probable that you will not. Just because at that point, after just 3 years of not getting pregnant, your statistical chances per month are less than 3%. By 6 to 7 years, you're in the 1% or less category now. And so, you definitely want to see someone. I would even make the caveat that if you actually take a few years to get pregnant, so let's say you get pregnant after 2 years, And then next time it takes 4 years to get pregnant. And then, now you're seeing a fertility doctor. That usually means there's a problem. So there's either a sperm issue, there's an ovulation issue, something's going on that can repeat itself, that has a pattern. Because as everyone knows, tubes can't open and close, but sperm can fluctuate, ovulation can fluctuate. So yes, I would say that yes, you can assume that you probably won't get pregnant naturally, but no one can ever say never. As long as there's open tubes and there's sperm and there's eggs, there's a chance, but it's just probability is low. Anything to add to that, Dr. Salem?
No, I completely agree. I mean, I think once you get that far out into the window, there's so many things that could be happening there. And, again, it's very common that it can be like a fertilization issue or something in which it's just practically impossible to happen, or we're getting to the numbers where it's functionally so low that it's not worth continuing to try. And what the one thing that I see here oftentimes that and I certainly don't want to discourage anybody from doing this, but is that people will try to get pregnant for 5 to 6 years, and then they will go through a very long drawn out process of trying a lot of things like supplements and many other complementary treatments and alternative treatments and things of that kind. And then unfortunately, I see them maybe a year or two after that. And I think that if it hasn't happened in 6 years, it's relatively unlikely that a supplement is going to fix it. And there's probably something more at a molecular level, fertilization level. Sperm counts are very, very low, so we need to do something for that. So anyway, I take caution, especially in those groups of people, that they hopefully don't waste too much time.
Yeah, and you're right. I mean, there are people out there who will try things. Take this supplement, try, take this, put this. Someone asked me today if they put castor oil packs on their abdomen, will that help their uterus? And you're right. I mean, there's a point where there's so much time that's gone by that there has to be something wrong. I always tell people all the time, when it comes to unexplained fertility, that does not mean there's not a problem. It is impossible to not get pregnant over all that time. And so the question is just, we don't always know where it is. It's not always obvious. Right. So I know we got some other questions that have been coming in here. I think, one other area that I know you and I are really big on this, we really feel like there's a lot of almost like fat phobia out there for fertility. And, and I feel like a lot of doctors, I see this from patients all the time, and they're almost discouraged to want to do fertility. They, someone say to them like, oh, lose some weight. That's what you need to do first. And then, and then come back. And this is OBs tell people this, there's family doctors. And there's this, I think that's one thing to really kind of explain. But if you're hitting any type of resistance and someone's just blaming your weight, go see a fertility doctor, because people do not get pregnant just because of weight. I'm not saying weight can't cause issues, but it's the underlying issue that's the problem. The weight might make it worse, but weight itself is not going to make you not get pregnant. And unfortunately, I see that a lot where people don't see a fertility doctor because, they're worried that, like their OB or someone like that told them, they're afraid like, oh, they're just going to say lose weight. And I can assure you that most fertility doctors, I can't say 100% because I don't know them all, but most are going to agree and say, no, they're not going to tell you should go lose some weight. And there's actually a recent study. I used to say this all the time. I used to get so mad at these patients I would see who would be like 40 years old or 41, and they would see a fertility doctor in town, and they tell them, well, you have to lose some weight first and then come back. I'm like, if they spend 6 months losing weight, their chances go down even more because of age. This is insane. Like, what are they thinking? And I would see these patients, and finally, there was actually some actual real life data now that's come out and said, yeah, you're actually hurting their chances. Like, you need to treat them. Don't sit there and just tell them to lose weight. And so, I don't know. I think that was something, when we're talking about when to see a fertility doctor, that's one thing is, if you ever feel discouraged or you're afraid to things like that, go see a fertility doctor, because we understand we're not going to sit there and just think, oh, it's weight. So,
yeah. I mean, I've even heard the opposite things where at some places they will actually not see patients with, a certain, they'll not see patients above a certain BMI or something like that. And I was very happy that the ASRM, our kind of big society for reproductive medicine, they came out very clearly with something that you and I have been talking about for what feels like forever, basically, which is you should never discriminate on a person's weight for the purpose of trying to get pregnant. And it's just like you said, Dr. Amols, it's not like it's something that we can't work on in conjunction with everything else. I mean, there's always healthy weights and all this kind of stuff. We know that. But I think for too long, what we've seen is the opposite story, which is our whole story is, when should you go see a fertility doctor? And I think there's this storyline in the background of, well, you shouldn't go see a fertility doctor if you're overweight. And that's not true. That's absolutely not true.
Yeah, there was actually a question. I didn't even see it until just now, but they were asking, could weight loss help with pregnancy? And that's a tricky question because, just like I said, the weight itself isn't causing the problem. But if you have a condition such as anovulation, I mean, you're not ovulating, that is due to insulin resistance, which is what PCOS is, and your weight loss could then allow you to start ovulating again, then yes. And so in that situation, as Dr. Salem just said, in conjunction, it helps. It's not the cause, but it helps because then it reduces that inflammation, the insulin resistance, and that helps you ovulate. There's also some data out there that shows that with a BMI under 30 or less does have better outcomes, and especially when it comes to things like gestational diabetes is reduced. So there is some benefit as well. But again, it doesn't mean, obviously if you're one of those people, as I mentioned, who are older, you really don't have time to focus on that. You really need to focus on getting pregnant and, not focus so much on the weight. Now, if you're someone who's younger, you're 24 and you go, it's pretty reasonable to say, hey, I'm going to take 6 months. I want to get my BMI down to have a healthier pregnancy. And there's nothing wrong with that. So.
Absolutely.
And just like we said, one person wrote, I was told that losing weight would be the best to get pregnant. And again, that's never bad. Trust me, I need to lose weight. I'm not even trying to get pregnant, but it's always good for everyone. But it really doesn't have as much of an outcome. Only time it really can make a big difference is if you're not ovulating. And that's why you hear these stories of women on Ozempic who, or weight loss surgery. And then all of a sudden they get pregnant. It's because they weren't ovulating before. They thought they were, but they were just bleeding every month. And then when they lost the weight, the insulin resistance dropped, their body started ovulating, and then they got pregnant. But again, that's a unique condition, and most people don't walk around having anovulation due to it. So that's a very unique thing. One of the questions that came up, are uterine pops common in IVF? I've never had uterine pops until I started doing IVF. This is a kind of interesting one. This is one of my podcasts coming up, so it's kind of interesting. So I'll give a little kind of preview of my podcast when we start talking about this. But I'd like to hear your view on if polyps are more common in IVF.
Okay, this is a good one. Well, so I will say that probably among people doing IVF, we find more polyps, but it's because we're looking for it's because we're looking for them. So polyps have been associated with, decreased implantation potential and decreased opportunity for this, embryo that was so precious to implant and continue into the pregnancy. And as a result, we're, fertility doctors tend to be kind of OCD about things, and we're kind of looking for every little thing that we can kind of optimize as we are, doing the embryo transfer. And definitely one of them is to look inside the uterus. That's pretty standard, kind of guideline based care to make sure that there's nothing in the uterus that would prevent the pregnancy from taking. Now, here's the thing. We're looking inside everyone's uterus that's going to have an embryo transfer. Nobody does that before they're getting pregnant, the old fashioned way. Some people might even think that's a little invasive. So, it's definitely one of these things where, if you go looking for it, you're going to find something. And I think there's a big bias there. And that's why, we do tend to see more polyps in our population than if you were probably to compare another group of people. But the polyps absolutely exist among people not going through IVF. And you know, it's just that they tend to get pretty big by the time they're causing symptoms that people go in and do it. We're doing it as a screening test, and then we find the polyp.
Yeah, and it's exactly what I'd say. You know, I liken it to cyst. You know, one of my favorite comments is I'll have a patient who's going through and she's like, I've never had a cyst in my life. She's like, and I go, oh, so you've had ultrasounds every month for a period of a year and a half? She's like, well, no. I go, you probably had cysts. You just didn't know it because you didn't, you know, they weren't causing you any discomfort. And when you go looking for something, you're going to find it more often. And as you said, when it comes to polyps, I think there's two parts to it. The first part is, like you said, we're looking for it. We know polyps occur in women. And if you're not even trying to get pregnant, it may not be an issue. And they actually can even pass on their own. You do not have to actually undergo a surgery to remove a polyp every time. Sometimes you do, but a lot of times they pass on their own. The problem is most people don't want to wait a year or a year and a half before doing a transfer. So they're like, no, I'd rather remove the polyp now. If someone, I had a patient one time, a very interesting, very scientific patient. So she was brilliant, and she's actually at ASU. She's a researcher, and she came to me and she's like, "No, I read that I don't have to do the procedure. Can I just wait?" I said, "Absolutely. It will eventually go away." And I said, or eventually it will get so big that will become problematic. We'll have to remove it. And she waited like a year and a half, and it finally went away. And then we did the transfer. And she was okay with that. So I think, like you said, that first part is we're not looking, right? It's like cyst. It's like even uterine septums. People have uterine septums that we don't know about. People have heart-shaped uteruses we don't know about. And then all of a sudden they get a C-section, we find it. So there are things out there that we don't know the true incidence of because we're not looking for it. And so in IVF, we're just looking more.
Right.
But the second thing is that we have more to lose. So if you have a polyp in your uterus and it's not causing you any problems, you don't see a doctor. And even if you did, they're like, there might be a little polyp there. We'll just check it again in 6 months. But when you go through sticking yourself for 10 straight days with, 30 injections eventually, and, this might be your second cycle, your heartache and stuff, and you have this embryo, do you really want to take a chance going, well, that polyp may not cause a problem? And so I think we are going to be, more apt to remove it. And I think that's the other reason why we make a bigger deal of them. Because, I mean, there are some polyps I would never do anything for as a gynecologist. But as a fertility doctor, I'm like, hey, we should probably get rid of that because you got one embryo left. It's right in the area to implant. Now, you and I know is that clinically, the big problem with polyps is really women who are more mature. So women who are like postmenopausal, whole different scenario. They cannot wait. You see a polyp in the postmenopausal woman, you take it out because it could be cancerous. And I know that's a question people come up. Can they ever be cancerous? They can. Usually the people that they're going to be cancerous on are menopausal women or women who don't get periods all the time. So someone who has like hyperplasia, has irregular periods, that's another time that you can see them. People ask me all the time, what causes them? What do you tell people when it? Because, I mean, we don't have like an exact cause, but I mean, I just wonder what you tell them. I can tell you what I tell them. Is I tell them it's part mechanical and also part hormonal. It's right. Things rubbing together, hormonal. Just like you get skin tags in your neck, people can get. Insulin can increase the chances of them. There's things like that. But what do you tell people when they ask that question?
Yeah, no, I think there's probably a lot that we still don't know about polyps. It is absolutely, there is like a hormonal component, like you're like you're saying, and I always say that too. I think having long periods where you have kind of this unopposed estrogen, always having estrogen around and not having regular periods may kind of predispose you a little bit more to having a polyp. There's also probably like genetic factors. I mean, we know some women just, you take out the polyps, you look a year later and they have polyps again. And so some people must be predisposed to the, underlying genetic machinery that's turning on certain things that are predisposing them to building these polyps. So there's probably, kind of this genetic component as well. And part of it is probably like a whole host of factors that we don't entirely understand yet. It's one of these things where, women's health continues to undergo like rapid progress, but has been under researched for a long time when you compare it to maybe some other fields like cardiology or something. And many people are doing phenomenal work and have continued to do phenomenal work, but there's still a lot that we don't know. And sometimes when we give, I think, some of these answers is because, you know, the depth of our understanding of some of these things is not as far down as one would wish. But obviously we know a lot about polyps, but, you know, again, but what's your take on it?
Yeah, I mean, you know, I think one of the things I do in my standard testing is any patient I know that has PCOS and has irregular cycles, I always get a sonohysterogram. And I tell them because I tend to find polyps are higher in people who have higher estrogen levels and who, you know, have irregular cycles. And that's kind of exactly what we expect for hyperplasia, right? So hyperplasia, which is, for people who aren't aware of that, is when the endometrial tissue makes more cells, and it's like the precursor to cancer. It's very far in the precursor, but the very beginning stage, and we call it hyperplasia. And on the cellular level, when you look at the microscope, you see more cells and crowding the cells and stuff like that. And so we know that there's some association with polyps with that. And so I do think, like you said, when people are going through IVF or given the higher estrogen levels, that's a big component of it. And you know, that might be why we see it more also in IVF, is because we're doing that. But I don't know. Like I said, I always tend to look for people who, you know, can have higher estrogen levels and insulin resistance are the ones that I get the most worried about polyps. I think the other interesting thing is, how do polyps cause problems, right? So I've seen doctors who have sit there and said, well, it's not right where the embryo is going to plant, so I'm not worried about it. And I don't agree with that. I tend to think of polyps in two ways. Yes, if it lands on the polyp, that's a bad thing because the blood supply is going to be low. But it just doesn't make sense if that's really the cause of problems. And I've seen patients who have polyps, they don't get pregnant. I remove the polyps, they get pregnant right away on their own. It definitely causes problems. I think of it more like an IUD, that the inflammation that's occurring by the body trying to get rid of it, because it is. I mean, these things, when they come out, they're inflamed. Usually you get like chronic, you know, inflammation on the report, and the pathology report. And so to me, I feel like we can't really say, well, that one's low, so we don't have to worry about it, or that one's up there. I feel like when you see them, the only answer really is you take them out, or you reduce the risk of potentially implantation.
Mm-hmm. Mm-hmm. I completely agree. I think there's like that local inflammatory process that's happening. And even the studies that have looked at, you know, why is it that they reduce the chances of implantation so much, haven't been entirely able to tell us why they decrease it so much. But it's impossible that the embryo is just landing on that little polyp that often. You know, that can't be the only reason. Yeah.
I know we only have probably about a little over 10 minutes left. And so I thought, you know, I want to make sure we kind of address the questions. Everyone who came here who, you know, is wondering, when should they see a fertility doctor? You know, that's another thing about irregular periods, you know. So if you are having spotting between your periods, so here's a period, there's a period, and you're spotting in between, that could be a sign of having polyps. And so that's another reason where, you know, if you're having problems getting pregnant, you know, see your gynecologist or a fertility doctor. One other thing is, I'm trying to think of anything else I can think of you know, about seeing a fertility doctor. And, you know, I think a lot of people get worried about cost. I think most people don't realize this, that almost 90% of people have diagnostic coverage if you have insurance. And sometimes some of these tests, you know, are very simple, and they can be, you know, a lot of times are covered. Like, for example, the test that looks for polyps is a diagnostic test. So you can just put it under painful periods, and it will be covered by regular insurance. It's not even a fertility procedure. And so, but I think the other thing is that I don't want people to think their doctors, OBGYNs, are holding them back because they're wanting to be the fertility doctor. Their intentions is actually very good, which is, there was a time when no one had insurance coverage. And the minute you walked into that fertility clinic, it was like, oh, we're not paying for anything, the insurance said, because that's fertility and you don't have coverage. And they were trying to protect the patients by doing some of these little basic tests, and that way saving people a lot of money and headache. Now, I mean, again, it's very, very uncommon that I see a patient that doesn't have at least some basic coverage in diagnostic. Like I said, 90% of people usually have some type of fertility coverage for diagnostics if they have insurance. Obviously, they don't have insurance, then it doesn't. So,
Yeah,
one of
I
the
think
things
that's
that,
yeah, no, I think that's such a great point. I mean, I think that we're in a, like, fortunately, like a very rapidly evolving time where diagnostic coverage is the norm. I mean, you know, most everybody has really great diagnostic coverage for many things, and many of which, by the way, can also be treated, you know, using their general medical insurance. And that's to say nothing of, you know, obviously all the people who have, you know, fertility coverage, which has been another really rapidly growing group of people.
yeah,
I mean, I always think all these things should be used judiciously. You shouldn't just go and use it all because you have it. That's not good medicine. But you know, it's definitely true that it's worth asking when you want to establish with your fertility clinic, if obviously, like, the major things, right? Like, do you take my insurance? Can I be, you know, can I be seen for diagnostic coverage? Um, I really encourage people not to be bashful about asking about what their out-of-pocket costs could look like. You know,
yeah,
I think if it's a genuine and good fertility clinic, they should be able to give them some estimates around these things. Um,
yeah,
and I know for the longest time, and this still holds true. I mean, we know this from Resolve, or like the National Patient Advocacy around infertility group. They still show that one of the biggest barriers is cost. That
mm,
people don't want to go get a fertility evaluation because they're worried about how much it's going to cost and everything. And so, I think it's really important to advocate for yourself as a patient. I think it's really important to know what is covered and to also know what's not covered, because then you're in the clear.
yeah,
Um, and then I think that should hopefully never be a barrier. You know, that's something that's been really important for you and I
yeah.
forever. And you know, I hope that it's virtually no barrier there.
Yeah, it's I I commend clinics like CMY, commend clinics guys they are trying to make it more affordable because we all those clinics we do make less, but we do it for the right for that reason is to allow people to do that. I was thinking before we get near the end here, there was a couple areas I was thinking about, like thinking again, like okay, when would I tell someone to see a doctor earlier? So one of them I was thinking about is kind of funny, which is if you feel like you've always been lucky, meaning like if you're like a guy or a girl who's like, oh yeah, like you've had a lot of, let's say, unprotected times in your life or relationships, you never got pregnant. There may be some fertility here. Are you really that lucky and you're just the one person who didn't get pregnant in all those encounters, or there's something there? And so I think history matters. If you're entering a new relationship, but you were in the relationship for 3 years without protection, let's say this is the more serious relationship now. Now you're like, hey, I want to have kids with this person. At that point, you really have to keep that in mind. You don't have to try for really a year at that point. I'd say 3 to 6 months. If you're not pregnant, go see a fertility doctor because you now have a history of infertility in your life. And that matters. I mean, that plays a part in the things. And so I think it's really important to look at everything from that standpoint.
Hey, Dr. Amos, we forgot a really big one.
But
We forgot a really big one. When should you go see a fertility doctor if you're thinking about egg freezing?
yeah,
So, this is one that is kind of interesting because it's a totally different, like, paradigm. It's a totally different, can of worms from thinking about going to see a fertility doctor for infertility. You're kind of, trying to stay ahead of things. And it's really confusing out there. I mean, there's a lot of stuff on social media that's like, you should go get your eggs frozen, only when you're this age, or you should only go get them frozen at this age, or beyond this age, it's no good. And I think this is, like, for a lot of people, a really tricky question because you don't have to. You could wait till next year to freeze your eggs, probably, or you could have gone last year to freeze your eggs. So there's no, you're not up against, your back's not up against the wall for any specific outcome because you're planning for something that's far off in the future. But I mean, When would you recommend somebody sees the fertility doctor for fertility preservation, egg freezing?
I don't think there's ever too early of a time. In fact, I'd say the minute you think about it, talk to them, because you know, I actually just saw someone. So I saw someone who's a pretty famous person. They're a big YouTuber and stuff like that. And they came to me to freeze their eggs because one of their family members had infertility, which again, another reason to see a doctor earlier is if you have a family history of fertility problems in the family. And they wanted to freeze their eggs. And I said to her, I go, listen, you can't. And for her, it was a drop in the bucket. It was like, it wasn't a cost issue. But I said, why? I mean, why put yourself through it? I mean, you're so young. I said, we can just evaluate your egg reserve over the years. And then if we ever see issues, then we can always freeze at that point. But I'm like, you're so young. It was, very early 20s. I said, until you're seriously in a relationship, I wouldn't worry about it. I don't think it's ever wrong to go early, right? Because, I mean, there's going to be situations where ovarian reserve is not good. I had a same-sex couple that came in one time. She was like 21. Her partner, I want to say, was like 33. And they were like, oh, 33-year-olds has to go first. We're going to get her eggs out and we're going to, have a baby. And I just said to them, well, listen, it's easy to assume that, but let's just test egg reserve on both of you. The 21-year-old was almost in menopause. I mean, it was so bad. And if I didn't catch it that day, they would probably never have kids from her eggs. And so it's one of those things where that's a very rare scenario. And I don't want anyone to freak out thinking, oh my God, I go to see my doctor, I'm 21. But it's just that point that I don't think it's ever wrong to go in early when it comes to fertility, because you just never know. I mean, trust me, even I sometimes wish, I'm like, man, when I was younger, I knew I had a varicocele. I knew something was going on, but I didn't know what it was. And when the doctor told me it was a varicocele, he's like, oh, you could do something about it. Or when you're ready to have kids, go see someone. I wish I would have done something more, because maybe if I would have fixed that when I was younger, I wouldn't have had infertility. But then, sometimes I'm very thankful how God gives us past, that for a certain reason. Maybe there was a reason I had to have infertility to get me to where I am today. But the point is, it's never wrong to go early. I know we only have a few minutes here, and I saw a couple questions I thought were kind of, kind of neat here. One of them was kind of questioning about what can be determined with a biopsy tissue from a procedure. And so I don't know if that's specifically talking about polyps, but if it's a polyp, we can know if there was inflammation, like how long it's been there. So something that's really inflamed has probably been there for a really long time. It's creating an environment that's not hospitable to an embryo. The other thing biopsies can be done for is they can find information. So there's things like called an ERA, endometrial receptivity assessment test. There's receptiva tests. So there's stuff in the endometrial tissue that you can look for infection. You can look at things like the RNA that's in there to figure out, what's happening in that lining at that time. So those are kind of things. Anything you can add to that question?
Yeah, I think you covered all the things that I would talk about in terms of the biopsy. I mean, very rarely do you find something else that's like concerning, like what you were talking about earlier, like hyperplasia or a cancer. That's so unlikely. But if you have suspicion, sometimes you can look for those things as well. But yeah, you can look at like chronic inflammation of the uterine lining, and you can see molecular clues for having endometriosis or adenomyosis with certain types of testing there. I think there's a lot more forthcoming in this field, right? Like, I think that this is probably our next big breakthrough is going to be implantation in our field. And it's kind of like the holy grail at this point, is how can we get great embryos to implant at a higher rate? And so I think the next 10 years we'll probably have a lot more innovation there. I hope. But yeah, for right now, I would say there's a spectrum of things we can look at, but it's limited.
Yeah. It's really interesting you said that, because I agree with you. I mean, right now, the biggest impact we had is the genetic testing on the embryos. I mean, that's made pregnancy rates go through the roof compared to the past. I remember, you had a 40-50% live birth rate with 2 embryos in the past. That was like amazing in the past, and then now it's like you have to put 2 embryos back to get that live birth rate. That, that's considered, poor. But I've always wondered that, the implantation, there's so many things that affect it. We were talking about fibroids earlier. Some people have questioned whether prolactin that comes from fibroids, could that be affecting like a local hormonal issue around the fibroid to the lining, even if it's not in the cavity. People talked about contractions. Is there someday we're going to be looking at contractions of the uterus, and then potentially that may have an issue in implantation. And then we talked about like the RNA, looking at the implantation potential. I mean, I think you're right. There's a day where I've told patients this before. There's going to be a month where you're going through and we do like a test. And we go, not this month.
Right.
Like embryo's good, but your uterus isn't. Let's hold off. And I think that's going to happen someday. And I know people are looking at metabolomics and stuff like that of the uterine cavity and trying to figure out that there's ways we can do it. But we have a long way to go in this field. I'm telling you, my part though, I'm still excited about. I told you, is like Gattaca, where we can just take the little biopsy sample and we can make all the embryos inside, and then we just pick the ones we want. But we're not there yet. That's probably a lot further away. So, anyways, I always want to encourage people. Please, come on the show. Don't be afraid. There are no dumb questions, and there truly are no dumb questions. I always tell people, if there were dumb questions, then I'm going to be really upset that I had to do 16 years of schooling to get to this point. Because if you already know what I know, that really frustrates me, because that was a lot of money and a lot of work. So never be afraid to come on the show and ask a question. You'll be surprised. There's probably about another 1,000 people out there who have the exact same question as you.
Absolutely. Yeah, we always love it, and looking forward to future shows with you, Dr. Amols, and to anybody who drops in as well.
Yeah. Well, we'll see you guys again in about 2 weeks, and we look forward to the next show. Have a good one.